Okay guys, let's start the general pathology revision express. So first we'll be starting with necrosis, which is defined as denaturation of intracellular proteins or from the progressive degradation action of enzymes on irreversibly injured cell following cell death in living tissue. So basically what are the three keywords you're going to write there? One is denaturation of intracellular proteins, the next one is progressive degradation action of enzymes which is on irreversibly injured cell following cell death in living tissue. What is the hallmark there? Hallmark of necrosis is loss of integrity of cell membranes. The cell membranes will not be integrated, they are broken. Morphological features on light microscopy will be increased eosinophilia, glassy homogeneous cells and moth-eaten cytoplasm and myelin figures. What coming to the gross patterns, the first pattern is coagulative. So coagulative necrosis is because of ischemia which has led to the necrosis. Ischemia leading to necrosis is coagulative necrosis. Basically there is protein denaturation here. The organs affected here are all solid organs except the brain. Examples are myocardial infarction, viral hepatitis and splenic infarction. There should be a ischemia, remember. Next, coming to liquefactive necrosis, that is because of enzymatic digestion. Because of enzymatic digestion, mainly because of proteolytic and hydrolytic enzymes. Mainly hydrolytic enzymes, then it is proteolytic enzymes. Organs affected mainly here is brain. Okay, the brain is the only organ which will be showing the liquefactive necrosis. Usually this type of necrosis is associated with infection. It is associated with infection. What is an example for this? It is brain abscess. Brain abscess is the examples. Next is gangrenous necrosis. Coming to the gangrenous necrosis, there are two types of gangrenous necrosis, that is dry gangrene and wet gangrene. Okay, dry gangrene and wet gangrene and gas gangrene. These are the three types. Okay, dry gangrene, wet gangrene and gas gangrene are the types of gangrenes. We are going to discuss mainly two types here, that is dry gangrene and wet gangrene. In case of dry gangrene, you are going to tell about coagulative necrosis. In case of wet gangrene, you are going to tell about liquefactive necrosis. So how we are going to compare them? It is easy if you compare them and read. It is non-infective because it is due to ischemia. Liquefactive is infective because there is some fluid present and that fluid will act like a cultural media for the infection to set in. Here it is due to ischemia, here due to hydrolytic enzymes or proteolytic enzymes. Here the line of demarcation is present, here it is absent. Then what are the examples here? Peripheral arterial disease due to atherosclerosis in case of diabetes mellitus and smoking patients. Okay, there is peripheral artery disease. So what is gross here? Gross, the infected area will look dry, shrunken and darkish red. Okay, darkish red or brown to black. These are the types of dry gangrene varieties. So next you are going to tell about the wet gangrene. Where is it common? It is common in moist places. It is common in moist places such as gut, mouth, cervix, vagina. All these are the sites which are common for wet gangrene. Coming to the gross morphology here, it is edematous, soft, rotten and darkish. It is edematous and it will be glistening, that is it will be shining. Okay, because of the fluid present there, it is shining. Next we are going to tell about the other necrosis such as caseous necrosis, fatty necrosis and fibrinoid necrosis. Coming to the caseous necrosis, it is most commonly seen with TB infection. Gross, you are going to see the areas of friable areas of white necrosis and microscopy will show granulomas. Remember, granulomas are seen very specific here. Fatty necrosis. In case of fatty necrosis, it is common in fat-rich tissues such as pancreas and gastric mucosa because of high lipase activity. They target this particular organs. Next, fibrinoid necrosis. Coming to the fibrinoid necrosis, it is most commonly seen in blood vessels and it is immune mediated. Immune mediated reactions will lead to this particular fibrinoid necrosis. And the examples are SLE and polyarthritis nodosa. Okay, because both of these diseases they are going to involve the vessels. Next topic is apoptosis. How you are going to define apoptosis? Apoptosis is a regulated pathway of cell death in which cells destined to die activate the intrinsic enzymes that degrade the cell components, which is in a programmed manner. So what are the keywords you are going to write? It is regulated, intrinsic enzymes and programmed. These are the things you are going to mention in your definition. So what are the causes? There are two types of causes. Either it should be a physiological cause, either it should be a pathological cause. Okay. Physiological cause is because of embryogenesis. Unwanted things in the embryo will be removed off. That is called as apoptosis. Then withdrawal of hormones like bleeding. That is called as progesterone withdrawal bleeding or estrogen withdrawal bleeding in case of menstrual cycle. The cells will be dependent on progesterone. Once the progesterone levels come down, there will be bleeding. If the progesterone levels are maintaining, then it will lead to pregnancy. Then removal of self-reactive lymphocytes and inflammatory cells. Pathological, what are the things you are going to concentrate? DNA damage and CD4 T cell mediated viral infection removal, okay, and tumor cells removal, misfolded proteins, all these come under pathological apoptosis. So what is the mechanism of apoptosis? The mechanism of apoptosis will occur in two phases, that is initiation phase and execution phase. So what are the two phases you must remember there? Initiation phase and execution phase. What are the apoptotic proteins? What are the apoptotic proteins? Remember, anti-apoptotic, pro-apoptotic and sensors. So what are the anti-apoptotic? In case of anti-apoptotic factors, remember always there will be L. Okay, there will be L. So BCL, MCL. Always there will be L present in case of anti-apoptotic because they are long living. Okay, L for long living. It is anti-apoptotic. If there is no apoptosis, they live for long duration. That is why L is present in them. Next, remember pro-apoptotic. Pro-apoptotic are backs and back. Next, coming to the sensors, it is bimbid bad Knox puma. Remember and repeat when I tell. Bimbid bad Knox puma. That is how you are going to remember. Inculcating repeatedly will lead to the memory. Bimbid bad Knox puma. Bimbid bad Knox puma. Bimbid bad Knox puma. Next, we are going to tell about in detail regarding the initiation phase. So in initiation phase, you are going to mention about two pathways, that is intrinsic pathway and extrinsic pathway. In case of intrinsic pathway, it is also called as mitochondrial pathway. It is also called as mitochondrial pathway. The extrinsic pathway is also called as death receptor mediated pathway. So intrinsic pathway, because of some stress event, there should be some stress event. Because of the stress event, that will be sensed by the sensors. Which are the sensors? I told you, repeat. Bimbid bad Knox puma. Bimbid bad Knox puma. These are the sensors. You are going to write it there. I have not written here, but you are going to mention it. So it is being sensed by the sensors. After the sensors are sensing it, they are going to activate whom? They are going to activate the pro-apoptotic factors. Which are the pro-apoptotic factors? They should not contain L. If L is there, then it is anti-apoptotic. If it is not there, then it is pro-apoptotic. So which are the factors there? Back and backs. These are the two factors which are seenly activated. So after activation of this particular pro-apoptotic factors, what it will lead to? It will lead to the release of cytochrome C. Remember, cytochrome C is released into the cytosol. So by what happens? Correspondingly, there will be inhibition of anti-apoptotic factors. Remember, if pro-apoptotic factors are increasing, it means that the anti-apoptotic factors should decrease. The same way, this cytochrome C will make sure that the anti-apoptotic factors are decreased, and the pro-apoptotic factors also will make sure that anti-apoptotic factors are inhibited. So once this cytochrome C is formed, what is the function of this particular cytochrome C? Cytochrome C will bind to APAF1. What is APAF1? APAF1 is apoptosis activating factor. The name itself says it activates the apoptosis. That's why it's called as apoptotic activating factor. That is APAF1. So once this APAF is formed, what is there? This particular cytochrome C and APAF combination forms something called as apoptosome. So you remember there is something called as apoptosome, which is formed because of combination of cytochrome C and APAF1. See, after this formation of apoptosome, what it does? It binds to procaspase 9. It binds to procaspase 9. So after this apoptosome binds to the procaspase 9, the procaspase 9 will be converted to caspase 9. So this is the end of intrinsic pathway. Now we'll go for extrinsic pathway. Extrinsic pathway, we told that death receptor mediator pathway, right? So there should be some death receptors. Death receptors are mediated here. So the fast ligand, remember the fast ligand will bind to 3 to 4 molecules of FAS. Okay, there is something called as fast ligand which will bind to the FAS itself, because these initially the fast molecule will be single, so the fast ligand will not be binding to this particular fast. So these fast molecules, what they do, they combine 3 or 4 molecules, they combine to form some big molecular structure, so that this particular fast ligand is going to bind to the fast molecule, which is huge. Now after this formation, what happens? After this formation is occurring, there is something called as FAD occurrence. What is FAD occurrence? That is fast associated death domain. That's why it's called as death receptor mediator pathway. Remember, because of formation of FAD complex, that is FADD, fast associated death domain, it is called as death receptor mediator pathway. Once this FAD is formed, what does this FAD do? This FAD binds to the procaspase 8. FAD binds to the procaspase 8. So after binding of this procaspase 8 and 10 to this particular FAD, what happens? They get converted to active caspases, that is 8 and 9. These are the key enzymes which are required for apoptosis. Okay, never forget, these are the 3 key factors, that is caspases are the enzymes which are very much required for apoptosis to occur in our body. There are 2 types of caspases. One is initiation caspases, that is 9 in case of intrinsic pathway, 8 and 10 in case of extrinsic pathway. Something next I'll tell, that is called executionary caspases, that I'll tell in execution phase. So next we are going to execution phase. So what happens in execution phase? Irrespective of anything, there will be convergence of initiation phase. There will be convergence of initiation phase. So both the phases, that is intrinsic pathway and extrinsic pathway, they converge together to form the execution phase. So after this initiation phase convergence, what happens? The caspase 9, 8 and 10, they form the caspase cascade. So there is something called as caspase cascade formation because of combination of all these 9, 8, 10 caspases. So after this cascade it is activated, what happens? There is activation of executionary caspase. I told the executionary caspase I will be telling, right? Those caspases are here. Those caspases are called as caspase 3 and 6, which will bring about the execution of apoptosis. How are they going to bring about the execution of apoptosis? They are going to activate DNase enzyme. They activate DNase enzymes. Once this DNase enzyme is activated, what happens? DNA is fragmented. Okay, the cell itself, the cell's main center is DNA, right? It's because the same DNA will be broken down now. The cell will not have any basis for its next future upgradation. So DNase enzymes is going to break down the DNA, and that will lead to apoptosis. Once this apoptosis is done, there are 2 things you must remember. One is the cytoplasmic blebs and apoptotic bodies. These are the things which are going to be formed. Remember them, okay? These are the 2 things which are formed. Next, coming to the morphological changes. Morphological changes in apoptosis. One is the cell will shrink in size. Okay, the cell will shrink in size. The next is chromatin condensation and formation of cytoplasmic blebs and apoptotic bodies. So at last, this apoptotic body should not be left like that only. It should be phagocytosed by the macrophages. Okay, that is the last step of apoptosis, that is phagocytosis of apoptotic bodies. What are the diseases? What are the diseases with apoptosis? There are 2 diseases basically. One is due to increased apoptosis, one is due to decreased apoptosis. You know, the cancers, you should never forget. The cancers is increase in the abnormal cell proliferation, increase in abnormal cell proliferation. That is because of decreased apoptosis, arrest will be there. That is also a key feature of cancers, never forget, or malignancy. Next is because of increased apoptosis. If there is increased apoptosis, the cells which are present will lead to the degradation. The normal cell itself will undergo degradation. This is seen basically in the CNS conditions such as Alzheimer's disease and Parkinsonism. The brain matter is going to be degraded. Slowly the brain cells are degraded here. Because of that only they develop the dementia. Next, coming to the difference between the necrosis and apoptosis. Difference between the necrosis and apoptosis. Coming to the cell size in necrosis is increased because of inflammation. All the inflammatory mediators come inside the cell and they lead to the hydropic change, and because of this there is increase in the cell size. Whereas in apoptosis there is cell shrinkage. Never forget, it is decreased in case of apoptosis. Cell number. What happens in necrosis? Usually necrosis is not in a small quantity, it is always in a big quantity, at least involving some particular tissue or some part of the body. That is why necrosis is seen in many cells. Whereas in case of apoptosis it is due to few cells or only single cell. Few or single cell. Okay, it can be due to few or single cell. Write it here, I have not written, please write it. Few or single. Few or single. Next is plasma membrane. What happens to the plasma membrane in case of necrosis? It is disrupted because of inflammation. The plasma membrane, I have told you, the cell membrane integrity is lost. That is a hallmark of necrosis. What I have told in necrosis initially was disruption of the plasma membrane. It is hallmark. Never forget, it is the hallmark of necrosis. You must write this point when you are writing about necrosis. Whereas apoptosis, it is intact. What happens to the nuclear changes here? Nuclear changes in necrosis, you are going to see the irreversible change. Both of these are irreversible change of cell injury only. Necrosis and apoptosis both are irreversible, they cannot be stopped. So nuclear changes in case of necrosis is pycnosis, karyorecris and karyolysis. These are seen in necrosis. Whereas in case of apoptosis, you are going to just see the fragmentation of nuclear DNA. You are going to see the fragmentation of nuclear DNA. What about the cell contents in case of necrosis? There is inflammation. Now what happens if there is inflammation? There is damage to the cell membrane. So the cell membrane will get perforated and it is disrupted. Since this plasma membrane is disrupted, what are the contents in that cell? They leak out. Okay, they leak out because of the disruption of the plasma membrane. Whereas in case of apoptosis, it is intact. Since the plasma membrane is intact, the cell contents will not come out and they will stay inside the cell. Whereas inflammation is present in case of necrosis. I have told you, inflammation will be present in case of necrosis, whether it is, and in apoptosis it is absent. So what is the cause now? What is the cause? Necrosis is always pathological. Never forget, it is always pathological. Whereas apoptosis, it can be physiological or pathological. Okay, it can be physiological or pathological. Okay, don't forget. Next, we are going to deal about the cell adaptations. We are going to deal regarding the cell adaptations. So how we are going to define the cell adaptations? Adaptations, remember, injury is different and adaptation is different. In case of cell injury, there are two types. One is reversible cell injury, other one is irreversible cell injury. In case of reversible cell injury, adaptations are also one type. Okay, adaptations are reversible changes. Reversible changes in what? In size, number, morphology and metabolic activity or functions of the cell in response to stress. Okay, so what are the things you must remember here? Keynote. One is irreversible. In what? Size, number, morphology, metabolic activity and functions. Okay, these are the things you must write in your definitions, which are triggered because of stress. Never forget, it is because of stress. What are the types of adaptations in the cell now? One is hypertrophy, next is hyperplasia, atrophy and metaplasia. These are the four cell adaptations mainly seen in our body. Never forget, these are the four adaptations. Coming to the explanation of each now. What is hypertrophy? Hypertrophy, there is increase in the cell size. Because of this increase in the cell size, that will lead to the increase in the organ size. Mainly these are seen in non-dividing cells. So what happens to the mechanism of action here? What is the mechanism of action? It is because of increased production of cellular proteins. It is because of increased production of cellular proteins. What are the types here? Physiological and pathological. Again here, physiological hypertrophy, it is seen in case of pregnant uterus and lactating breast, and skeletal muscles in case of gym activists. The people who are going for gym will have skeletal muscle hypertrophy, whereas lactating breast in case of lactating females in their postpartum period to feed the baby to express the milk, whereas pregnant uterus will undergo hypertrophy because to accommodate the increasing size of the fetus, whereas pathological hypertrophy is seen in case of LVH. It is seen in case of LVH because of prolonged hypertension. There is concentric LVH you are going to see in case of hypertension patients. Next is hyperplasia. What is hyperplasia? Hyperplasia, there is increase in number of cells. There is increase in number of cells. Here it was increase in number of size. Here it is increase in number of cells. That is hyperplasia. So how is it mediated? So what is the mechanism of action here? The mechanism of action is growth factor driven cell proliferation. There is growth factor driven cell proliferation. That is the mechanism in case of hyperplasia. Again, there are two types. One is physiological, the next is pathological. Physiological, it is again breast during puberty and pregnancy, and the liver which undergoes hyperplasia after the partial resection. After the partial resection. Next is pathological. So what is pathological? Pathological, mainly there are again two, that is endometrial hyperplasia and BPH. Endometrial hyperplasia is pre-malignant, whereas BPH is not pre-malignant. Remember, it is not pre-malignant. Endometrial hyperplasia will lead to endometrial carcinoma, whereas BPH will not lead to prostatic carcinoma. Remember, it will not lead to prostatic carcinoma. So coming to the metaplasia, what is metaplasia? Metaplasia is again the reversible change in which one differentiated cell type is going to be converted to the other cell type. One cell type is converted to the other cell type. Remember, it is converted. Remember, converted is important in the definition, and it is reversible. All these are reversible. Remember, all these are the reversible changes. What is the mechanism of action in case of metaplasia? Remember, it is reprogramming of reprogramming of stem cells. Reprogramming of cell death is called as apoptosis. Never forget, it's called programmed cell death. Whereas here it is reprogramming of stem cells that will lead to metaplasia. So what are the examples here? It is squamous metaplasia, columnar metaplasia, and mesenchymal metaplasia. These are the three things you must remember. So squamous metaplasia is seen in case of smokers. And here the normal pseudostratified ciliated columnar epithelium is replaced by stratified squamous epithelium, whereas columnar metaplasia is seen in case of GERD patients, where the stratified squamous epithelium is replaced by columnar epithelium. Then that condition is called as Barrett's esophagus. Next is mesenchymal metaplasia. It is seen in case of myositis ossificans. Next, the last change, that is atrophy. So atrophy, there is decrease in cell size and cell number. Both is occurring here. There is decrease in cell size and cell number. What is the mechanism? There is decreased protein synthesis and increased protein degradation. There is decreased protein synthesis and increased protein degradation. Again, two types here, physiological atrophy and pathological atrophy. Physiological atrophy is seen in case of thymus and notochord. Thymus and notochord are not present as we grow. Remember, right? Thymus is atrophied. Even notochord is also atrophied. Only remnants are seen. And pathological diffuse atrophy, if you are not using anything, then it will undergo atrophy. Senile atrophy, as you age, there is atrophy seen. Pressure atrophy, because of continuous pressure applied on particular tissue or organ, that will undergo atrophy. And if there is an ischemia and a reduced blood supply, and that will also contribute for atrophy. Next, coming to the cell injury. In cell injury, I will be dealing with both cell injury, that is reversible cell injury and irreversible cell injury. I will not be telling in detail. I will be telling about the detail outlines, that is pathogenesis and mechanisms, and you must remember and you must write in your exams. So what is a precipitating event here? What is a precipitating event in case of reversible cell injury? It is hypoxia. First thing is hypoxia. What happens if hypoxia happens? There is damage to the mitochondria. Once the mitochondria is damaged, what happens? There is decreased oxidative phosphorylation. In biochemistry you have learned, right? Oxidative phosphorylation, the site is mitochondria. Since the mitochondria is damaged now, there is no oxidative phosphorylation. So what is the function of this particular oxidative phosphorylation? It is the function of this particular oxidative phosphorylation is ATP synthesis. Since there is no oxidative phosphorylation, there is decreased ATP synthesis. There is decreased ATP synthesis. If there is a decreased ATP, there are three fates. Remember, three fates. First fate is there is decreased Na plus K plus ATPase pump activity and increased anaerobic glycolysis and detachment of ribosomes from the rough endoplasmic reticulum. These are the fates of decreased ATP synthesis. So once the Na plus K plus ATPase pump is not active and it is not more active, what happens? There is increased sodium influx and increased water influx and increased K plus efflux. So what is the main function of this Na plus K plus ATPase pump? To pump 3 sodium outside and 2 potassium inside, and wherever sodium goes, water goes. Okay, and wherever water goes, glucose goes. These are the 3 idiots, friends, you must never forget. That is sodium, water and glucose. They always go together in our body. Next, what happens is, if there is increased sodium influx now, increased sodium influx and increased water influx into the cell. If there is inside there is more water, what is it called? What will it lead to? It will cause cellular swelling, and that is called as hydropic change. Don't get confused. Hydropic change and cellular swelling both mean the same. You are going to write the same pathway from hypoxia till ATP synthesis, that is decreased, and divert your pathway to cellular swelling. Okay, after this cellular swelling, what does it lead? Now the cell is swelled. Now the organelles will start swelling. That is endoplasmic reticulum and mitochondrial swelling. Endoplasmic reticulum and mitochondrial swellings are seen. At the last is membranes are swelling. Okay, membrane is getting swelled. The outer membrane is getting swelled. And last is myelin figures, which are seen in both case of reversible and irreversible cell injury. It is seen in both. Okay. Next, after this, there is increased anaerobic glycolysis. Now, if there is increased anaerobic glycolysis, what happens? There is increased formation of lactic acid, that is lactate. The particular glucose is converted to lactate, and this lactate will accumulate and that will lead to lactic acidosis. You remember, right? In the glycolysis, the last formation is pyruvate, right? Pyruvate is formed using the enzyme called pyruvate kinase. And this particular pyruvate, what does it do? Either it should be converted into TCA cycle, acetyl CoA formation will be normally seen. But there are two fates. Either it can be converted to fumarate, either it can be converted to lactate. But thing is here, what happening is, because of anaerobic glycolysis, the lactate is predominating and that will lead to lactic acidosis. Since there is an acidosis, what happens? The pH is reduced. If the pH is reduced, there is the clumping of chromatin. Because of this decreased pH, the chromatin will undergo clumping. The last fate is detachment of ribosomes from the rough endoplasmic reticulum. The rough endoplasmic reticulum will be containing the ribosomes, and these ribosomes will detach from them. Ribosomes, what are they used for? They are used for protein synthesis. Now they are detaching, and because of this there is decreased protein synthesis. Remember, this is what's seen. This is called as hydropic change. This is called as hydropic change. For hydropic change, you are going to draw the same diagrams. First you are going to show the normal cell. This is what is normal cell. Remember, this is normal cell. This is normal cell. But here what happens? Now you are going to see the membranes are dilated or membranes are blebbed. That is called as membrane blebs. Next, dilated nucleus. The inner cells of the cell organelles and cellular components will get dilated, like dilated mitochondrium, dilated endoplasmic reticulum and dilated nucleus. This is called as Mickey Mouse sign. Mickey Mouse sign. In case of electron microscopy, this will look like a Mickey Mouse sign. And clumping of chromatin. Remember, this is clumping of chromatin. Next we are going to tell regarding the irreversible change. Next we are going to telling regarding the irreversible change. In case of irreversible change, there are two features you must never forget. One is profound disturbances in the cell membrane. Okay, there will be profound disturbances in the cell membrane, and the next is profound or severe mitochondrial damage. One is cell membrane damage, next is mitochondrial damage. These are the two things you must remember when it comes to irreversible cell injury. If the cell membrane is damaged, what happens? It is permeable to most of the things. Okay, it will lose its capacity. Selective permeability is lost, that is it loses cells selective permeability. The cell will lose its selective permeability. So if the selective permeability is lost, what happens? There is increased permeability to many of the things. In such thing, there is one ion called as calcium. That particular ion, it is very aggressive and it will stimulate all the enzymes. So in increased cytosolic calcium, you must mention in your flowchart, that is increased cytosolic calcium. If the increased cytosolic calcium is seen, what happens? It activates enzymes. So what are the enzymes activated? Phospholipase, proteases and endonucleases. These are the three things which are activated in case of irreversible cell injury. So what does phospholipase do? It will break down the phospholipids seen in the plasma membrane, that is the cell membrane. Next is proteosis. What does this proteosis do? It will break down the cytoskeletal proteins which maintain the integrity between the cell. They maintain the skeleton structure of the cell. That's why they are called as cytoskeletal proteins. Next is endonucleases. Since they are present, it is present inside the nucleus. What is present inside the nucleus? That is DNA. So they break down the DNA. These are the three things you must never forget in case of irreversible cell injury. That is the nuclear changes. First change is pignosis, that is clumping of nuclear chromatin. The nuclear chromatin gets clumped. Next is karyorexis. Karyorexis is fragmentation of nuclear chromatin. Last is karyolysis. What is karyolysis? Dissolution. The entire nucleus itself will disappear. That is called as karyolysis. Next, regarding the pigments. Coming to the pigments now. So what are these pigments? Pigments are colored substance. These are colored substance, can be exo or endogenous. Can be exo or endogenous in origin, which accumulate inside the cell and may or may not cause disease. May or may not cause disease. They accumulate. So what are the key words you must write in the pigments definition? That is, they are colored substance. They might be exo or endogenous particles which accumulate inside the cell, which may or may not cause the disease. What are the two types there? Two types are endogenous and exogenous. Exogenous most commonly be carbon, because carbon is very abundant in our earth, so it is the most common exogenous pigment. And tattoo, which is very fashionable nowadays. Next is endogenous. In case of endogenous, there are many things you must remember. Few of them are lipofuscin, melanin and hemosiderin, bilirubin and homogenesic acid. So we'll read in brief of each of these particular pigments. I'll mention 4 or 5 and we'll finish this particular pigments. Lipofuscin is called as wear and tear pigment. It is called as wear and tear pigment. Okay, it is called as wear and tear pigment. It is yellowish to brown in color. Derived from lipid peroxidation. It is derived from lipid peroxidation of polyunsaturated fatty acids of cell membrane. That is lipid peroxidation. Because of this lipid peroxidation of the cell membrane, they contain this polyunsaturated fatty acids that will release the lipofuscin pigment. So what does this particular cell membrane indicate damage? If there is a cell membrane damage, it indicates free radical mediated cell injury. It is a free radical mediated cell injury. Next, the brown atrophy of the organ is involved. Okay, it will look like a brown atrophy. That's what they mention, brown atrophy of organ involved. Most commonly seen in case of PEM and starvation. What is PEM? Protein energy malnutrition. That is kwashiorkor marasmus, which will be studying in case of vitamin and other deficiency, nutrient deficiency. Okay. Next is hemosiderin. So what is hemosiderin? Hemosiderin is also a storage form of iron and it is golden brown. It is golden brown in color, most commonly seen in case of systemic overload. There should be some systemic overload. Because of that, there is hemosiderin deposition, most commonly seen in case of CVC lung. There you are going to see hemosiderin laden macrophages. They are called as heart failure cells, which you are going to see in CVC lung. Remember, heart failure cells are not seen in heart failure, they are seen in chronic venous congestion of lung. This should be remembered. And you must remember that lipofuscin is a telltale sign of cell injury. Okay, if there is lipofuscin, it indicates cell injury. It's a MCQ for you people. Next is melanin. What is melanin? Melanin is a brown-black pigment. It is a brown-black pigment due to melanocyte proliferation. It is most commonly seen in case of malignant melanoma and nevus. Next is homogenesic acid. Homogenesic acid you have learnt in biochemistry, right? You have learnt in biochemistry. So what is it? It is seen most commonly in alkaptonuria because of the enzyme homogenesic oxidase. Next is bilirubin. Bilirubin is seen in case of jaundice and liver conditions such as liver cirrhosis, alcoholic hepatitis, or viral hepatitis. Most of the things are related to liver. Bilirubin is handled by liver, right? So you're going to see most commonly in liver conditions. Next is carbon. Carbon is an exogenous pigment accumulated in the lung. Okay, and most commonly carbon is accumulated in the lung because we are inhaling the carbon which is present in the air. So if it is accumulated in the normal lung, it's called as anthracosis. In case of normal lung, it is anthracosis. In case of diseased lung, it is called as pneumoconiasis. Coal workers pneumoconiasis. Most commonly this particular carbon, the peoples who are working in the carbon industries are more exposed. So it's called as coal workers pneumoconiasis. It's called as coal workers pneumoconiasis. Next we will talk about fatty change. Okay, we will talk about fatty change. What is fatty change? Basically it is intracellular accumulation of triglycerides. Okay, it is triglycerides, not cholesterol esters. They are called as xanthomas. It is seen in xanthomas, whereas fatty change you must mention it is triglycerides. That is called as steatosis. The definition is intracellular accumulation of triglycerides, which is called as steatosis or fatty change. What is the most common location here? It is liver. Okay, most common location being liver. It is called as fatty liver. The condition is called as fatty liver. So what are the causes? Causes are non-alcoholic causes and alcoholic causes. Alcohol is the second most common. Okay, here I have written most common now. Alcohol is second most common cause, whereas non-alcoholic fatty liver, it is NAFLD, that is called as NAFLD. That is the most common. Presently it is the most common cause NAFLD. Okay, remember. So what is a gross pattern? The liver will look enlarged. The liver will look enlarged, pale and smooth and glistening because it is having so much of fat. On the cut section it will be yellow because fat is yellow in color. When you are looking in your naked eyes, it will look yellow. So it is on cut section. C bar S means cut section. It is called as having yellowish to white appearance, and it is greasy and creamy. So what are the things you are going to appreciate in your microscopic features? You are going to draw the central vein here. In the center you are going to draw the central vein, that is central vein. Next you are going to draw what? Next you are going to draw the liver cells, normal hepatocytes, some of the normal hepatocytes. In between them you are going to draw the macrovesicles and microvesicles. Macrovesicles are large and they don't contain fatty deposits, whereas microvesicles, they contain the fatty deposits. Here, what about the architecture here? Here it is normal. Don't forget, the architecture is normal here. So what are the stains used? What are the special stains used to stain fat? It is oil red O and Sudan black. For melanin it is Mason trichrome. For calcium it is Von Cosa. These are some special stains. For glycogen it is PAS. Okay, for glycogen it is PAS. Next, autophagy. Coming to autophagy, what is autophagy? It is natural. Remember, it is natural. It is naturally regulated process in which the cell eats its own components due to nutrient deprivation. The cell eats its own components. That is called as autophagy. So what is an organelle involved here? It is lysosome. The organelle involved is lysosome. What are the two types? Physiological and pathological. The types are physiological and pathological. So physiological they have mentioned there, pathological they have not mentioned. One is physiological, chaperone mediated microautophagy and macroautophagy. In microautophagy only vacuole is formed, whereas in case of macroautophagy the cell contents will start moving inside the vacuole, that is called as macroautophagy, whereas pathological autophagy is seen in case of cancer. Because of anorexia nervosa, they'll not take so much of nutrients, okay, because their digestion power will decrease and they feel the stomach is always full and they take very less food, and that will lead to nutrient deprivation. In diabetes also, because of the calorie restriction, it happens. And neurodegenerative disorders, they are going to ask what is a marker. Never forget, it is LC3, okay, light chain myosin something, I don't remember, it is called as lysine, LC3, okay, LC3. Next we'll move on to the next chapter, which is very important in case of general pathology, that is acute inflammation. So what is acute inflammation? How we are going to define acute inflammation? If there is any inflammation of 4 signs, that is Scalar, Ruber, Dollar, and I don't remember one more, Scalar, Ruber, Dollar, okay, and tumor, okay, these are the 4 things you must remember in case of acute inflammation. So what are the major components to say it as acute inflammation? What are the components? What are the major components you must remember? One is dilatation of small blood vessels, so that that will lead to increased blood flow and increased permeability of blood vessels. Once there is increased permeability of blood vessels, that will lead to leakage of cell and proteins, okay, there will be leakage of cells and proteins, and movement of leukocytes from the circulation to site of inflammation, movement of leukocytes from circulation to site of inflammation. These are the things. Next is course of disease. What is the course of disease? There are 2 events occurring. One is vascular event, the other one is cellular event. So what happens in the vascular event? The first step is vasoconstriction. First is vasoconstriction to minimize the blood loss. The next is vasodilatation. The next is vasodilatation. To vasodilatation and increased permeability. Vasodilatation and increased permeability. This is the hallmark of this particular acute inflammation. Because of endothelial cell contraction, that will lead to vasodilatation and increased permeability. And stasis, that is slowing of blood flow, that is turbulent blood flow, so that the leukocyte comes in contact to the endothelial cells for further action. Next is margination. These are the 4 things which happens in the vascular event. Next is cellular event. Coming to the cellular event, in cellular event there is rolling. What is rolling? Rolling is basically loose attachment. The next is what happens in the rolling? There are something called as E-selectins and P-selectins which are present on the endothelium, and because of this there is adhesion of this particular neutrophils or the cells of acute inflammation. They bind to this E-selectin and P-selectin via silyl Lewis X glycoprotein, which is present on neutrophil. Remember, these 2, they are present on endothelium. This is present on WBC, okay, this is present on WBC, this is present on endothelium. So there is a binding between them. Because the cells will be moving in a faster rate, to slow it, you are going to put the road breakers. The road breakers are E-selectin and P-selectin to slow them. Once you are slowing them, you are going to stop them next. That is called as adhesion. That is a firm attachment, and the firm attachment is brought because of ICAM and VCAM. Okay, ICAM and VCAM. Remember, here it is E-selectin and P-selectin. Here it is ICAM and VCAM. So ICAM will bind to beta-2 integrins, and VCAM will bind to beta-1 integrin, which is present on the WBC. Next is transmigration. You are going to migrate that particular inflammatory cell towards the site of infection, so that it will fight that infection. So it should come out of that particular blood vessel, right, for the action. That is called as transmigration or diapedesis. So what is mediating this? It is mediated by PCAM1. The next process is called as chemotaxis. What is chemotaxis? You are going to make that particular pathogen or allergen or antigen very tasty for this particular neutrophil To make it tasty, you're going to bombard that particular bacteria with chemoattractants, and that process is called as chemotaxis, so that this particular neutrophil is going towards that particular pathogen and seeing it and having it nicely. That is called as chemotaxis. You're going to make the bacteria tasty for particular neutrophil. So what are the chemoattractants in our body? One is complement mediators such as C5a and leukotriene B4 and IL-8. These are chemotactics. So what is IL-8 doing? It is going to recruit the neutrophils towards the site of inflammation. That is a function of interleukin 8, whereas C5a and LTB4, that is leukotriene B4, is going to make the bacteria tasty. The next step is phagocytosis and killing. So in phagocytosis, again it's a 5-marker question. I have not elaborated here, make sure you study properly, but I have mentioned the basic things. You are going to put this particular flowchart if they are going to ask the phagocytosis. So phagocytosis subdivisions are: first is recognition and attachment, the second is engulfment, and the third is killing. Recognition and attachment is basically based on opsonization, whereas engulfment is formation of phagolysosome, and killing is based on oxygen dependent and oxygen independent. So opsonization. So what are the opsonins in our body? Fc fragment of IgG antibody and C3b. These act as opsonins. Okay, opsonization. Next is engulfment. How is phagolysosome formed? Phagosome and lysosome, they fuse to form the phagolysosome. Once this phagolysosome is formed, what happens? The killing is taking place. How is this killing taking place? There are two methods. One is oxygen dependent and oxygen independent. So oxygen dependent killing is called as H2O2 halide system. On the basis of this particular H2O2 hydrogen peroxide and halide system, oxygen dependent killing is occurring, whereas now oxygen independent is based on lysosomal enzymes. So we are going to just see the diagram of this particular acute inflammation once, so that will be easily revised. First is margination. The next is rolling, which is mediated by whom? Selectins, that is E-selectin and P-selectin, which bind to the Sialyl-Lewis X glycoprotein, which is present on the neutrophil. The third step is adhesion. Adhesion is complete stop. Rolling is put a humps or road breaker. Third is when they slow down, catch them, that is adhesion. That is mediated by integrins beta 1 and beta 2. VCAM is binding for beta 1, whereas ICAM is binding for beta 2. Next is transmigration. For the cell to act, it should be transmigrated or diapedized. It is mediated by PCAM. The next is chemotaxis. You are going to make the bacteria tasty by adding the chemoattractants C5a, LT, B4 and interleukin 8. So the neutrophil has come to the site of infection where the bacteria is found. That is in red in color. This particular red in color are the bacteria. They are going to be phagocytosed by the neutrophils, and they are called as phagosome. Once this particular bacteria is phagocytosed, it is called as phagosome. So this phagosome later will combine with the lysosome to form phagolysosome, and this phagolysosome, based on oxygen dependent or oxygen independent, is going to bring out the killing. This is what the overall overview of acute inflammation. Next we will tell about the chronic inflammation. Next is chronic inflammation. So what is chronic inflammation? It is inflammation that long lasts, about weeks or months, along with tissue injury and repair. Okay, there is both tissue injury and repair. These are the three keywords you want to write. It is long lasting, that is for weeks or months, and it is consisting of both tissue injury and repair occurring simultaneously. So what are the causes? Infections. Okay, there are long standing infections, hypersensitivity, diseases and toxic agents. These are the causes of chronic inflammation. So what are the cell mediators in chronic inflammation? It is mainly macrophages. And lymphocytes are also seen, but macrophages you must know in detail. There are two types they are getting activated. One is classical method of activating macrophages, the other one is alternative method. So what are the things which you are going to see? It is being induced by interferon gamma and endotoxin. These are the two things you must remember, and here it is induced by interleukin 4 and interleukin 13. Next, what happens, this interferon gamma and endotoxin, they release interleukin 1, 6 and 12. They release interleukin 1, 6 and 12, whereas interleukin 4 and 13 they produce interleukin 10 and TGF beta. So what is this particular function of this IL-6, IL-1 and IL-12? They form M1 macrophages. They form M1 macrophage. The macrophage, it is formed in the classical pathway, it's called as M1 macrophage, whereas the macrophage which is formed in the alternative pathway is called as M2 macrophage. Once this M1 macrophage is formed, what will that lead to? That is going to activate the reactive oxygen species and nitric oxide and lysosomal enzymes. After this is formed, what happens is killing of the bacteria and tissue destruction. Killing of the bacteria and tissue destruction. Now M2, M1 is done, M2. What does this M2 macrophages do? M2 macrophages, they are anti-inflammatory and they form the fibrosis, okay, fibrosis induction. Whereas M1, they kill bacteria and tissue destruction. Remember, M1 is going to kill the bacteria and tissue, both it is going to be destroyed. Whereas M2, it is anti-inflammatory. No, it is done. Already we have done so much of damage. Now it's time to patch up. That is done by M2 macrophage. It is anti-inflammatory and fibrosis is going to be formed. Now the granuloma. So what is granuloma? Granuloma is a collection of modified or activated macrophages called as epithelioid cells surrounded by the lymphocytic collar and giant cells. So what are the keywords? Epithelioid cells, lymphocytic collar and giant cells. Giant cells are also called as Langerhans giant cells. They are called as Langer giant cells. Langer giant cells. Not Langerhans, okay. Langerhans are called as antigen presenting cells in case of skin, that I will be telling in hypersensitivity reaction type 1. Here it is Langerhans giant cell. So this is the diagram you are going to draw in case of microscopy if they are going to ask. But before that, we are going to concentrate on the pathogenesis. How is the granuloma formed? There is some antigen. This particular antigen, it is detected by CD4-TH1s, okay. It acts on CD4-TH1 cells. So after this activation, after the maturation, they release interferon gamma. After the interferon gamma is induced, what does it induce? I have told interferon gamma is going to induce the M1 macrophages. Here the same way M1 macrophages is induced. Once this M1 macrophages is induced, there is a formation of granuloma. So you are going to draw the diagram. In the center you are going to see the caseous necrosis, which is surrounded by the epithelioid cells. These are the modified macrophages which are elongated, having the slipper shaped nuclei, and you are going to see the fused epithelioid cells. They are called as giant cells. These are big, huge. They are called as giant cell, and it is surrounded by a lymphocytic collar. I have not done the entire diagram. Please make sure that you are going to draw the full diagram. So Ghon's focus. So Ghon's focus or Ghon's complex or Ranke's complex. Everything it's called as Ranke's complex. It's called as Ghon's complex. It's called as primary complex. It's called as Ghon's foci. So many names. So it is most commonly seen in case of primary TB. Remember, it is always seen in primary TB. Most commonly seen in pediatrics, and it is most commonly seen in pediatrics. So what are the components of this particular complex? You are going to see the pulmonary component, lymphatic component and lymph node component. Pulmonary component is 1 to 2 centimeter solitary nodule. You are going to see the solitary nodule, which is 1 to 2 centimeter. You are going to see the solitary nodule. Next, this particular nodule will be having some lymphatic site, that is called as lymphatic component. Next, this particular lymph node, lymphatics will be drained to the lymph node, right? This is lymph node, this is lymph, and this is nodule, okay. NLLN, that is how I remember, okay. NLLN, that is, first is nodule, solitary nodule, next is lymphatics, next is lymph node, okay. Next we will tell about mediators. In mediators there are two types. One is cell derived, the other one is plasma derived. One is cell derived and other one is plasma derived. Cell derived are called as, there are two types, that is preformed and newly synthesized. In case of preformed, it is histamine, serotonin and Lysosomal enzymes newly synthesized are platelet activating factor, nitric oxide, leukotrienes, prostaglandins, and cytokines and chemokines. These are the things which are newly synthesized. Coming to the each description. Before that, we'll tell about the plasma-derived cell mediators. Plasma-derived are complement activated system, coagulation cascade, and kinins. These are the three things we're going to tell about mediators of inflammation. Next, histamine. What is the function? What is the source of this histamine? The main source of histamine is mast cell. The main source of histamine is mast cell. So, what is their function? It is vasodilatation, vasoconstriction, and increased vascular permeability. Okay, it is having vasodilatation, vasoconstriction, and increased vascular permeability. Next, serotonin. Serotonin, what is the source? Source of serotonin is basophils. After basophils, it is enterochromaffin cells of GIT. This is the source. Function is same as histamine. Okay, it is same as histamine. Next is platelet activating factors. What is the source there? All leukocytes. You are going to see all leukocytes and mast cells. Okay, mast cells are the source. What is the function? Platelet activating factors. So it is going to activate the platelet to form the aggregation. So it increases the platelet aggregation and it increases vasodilatation. It increases vascular permeability, but bronchospasm. It is the opposite here. Everything is increased except the bronchus. It is going to constrict it. That is bronchospasm. Next is nitric oxide. So what is the source of this nitric oxide? There is some amino acid called as arginine. From there, the enzyme called as nitric oxide synthase, that is NOS, that is forming the nitric oxide. So what is the function? It is a vasodilator. You have learned, right? Nitric oxide is a vasodilator which is used in angina, so many other things, MI, hypertension crisis, okay, nitroglycerin, nitroprusside. All these are things which are used in case of hypertension crisis, in case of angina, in case of congestive heart failure. There you are going to use the nitric related drugs, okay, because they cause the vasodilatation and they decrease the oxygen demand and thereby reducing the preload. Next, the function. So function is vasodilatation, smooth muscle relaxation, and decrease platelet aggregation. It is opposite of platelet activating factor. Next is leukotrienes. Leukotrienes, there are mainly 4 types. One is LTB4, LTC4, LTD4, and LTE4. Okay. Leukotrienes, LTB4 I have told it, right? It is used in chemotaxis, I have told in acute inflammation. Whereas LTC4, D4 and E4, they bring about vascular permeability. They increase the vascular permeability. But cause the bronchospasm. Next, prostaglandins. In case of prostaglandins, it is PGI2, PGD2, E2, F2 alpha, and thromboxane A2. So PGI2, it is causing increased vasodilatation and decreased platelet aggregation, whereas PGD2, E2, F2 alpha, all they have the same function, that is vasospasm, bronchospasm, and increased vascular permeability. Thromboxane A2. So what is the function of thromboxane A2? It increases platelet aggregation and vasoconstriction and hemostasis. Okay, and hemostasis. Cytokines. There are 2 types of cytokines which are released. One is acute inflammatory cytokines. The next is chronic inflammatory cytokines. In case of acute, it is IL-1, IL-6, and TNF alpha. Whereas in case of chronic, it is IL-12, IL-17, and interferon gamma. Bradykinin. So what is a bradykinin? It is a plasma derived mediator, right? So what is the function of this particular bradykinin? It increases vascular permeability. Vasospasm and bronchospasm, same like prostaglandins. Okay, these are the mediators of inflammation. Next, coming to the wound healing. There are 2 types, that is first, healing by first intention and healing by second intention, that is primary and secondary. Okay, first is primary, second is secondary. So first or primary intention healing is most commonly because of epithelial injury. There is just epithelial injury, just the epithelium or the outer surface is damaged, whereas in case of secondary, significant tissue loss should be present for secondary intention to set in. So what is the mechanism of action here? Basically, it is epithelial regeneration. Whereas in case of secondary intention, it is regeneration plus scar formation. Okay, regeneration plus repair. Repair is always with scar formation, whereas regeneration there is no scar formation. What is associated with the wound healing in case of primary? Inflammation, proliferation of epithelial cells, and tissue scar minimally, because this is the not major mechanism. Repair is not major mechanism in case of primary healing. Whereas in case of secondary, it is repair and scar formation. What is the example? Example is surgically cut wound. You are going to cut the wound and you are going to suture it, and that particular example is seen in case of primary intention healing. Secondary intention, what is the example? Like abscess or ulceration which has led to the tissue loss. So much of tissue loss is there, and what you are going to see basically here, you are going to see increased necrotic tissue and large fibrin clot and large granulation tissue and scar contracture. It is very specific. So what are the factors which are influencing the wound healing? Factors influencing, this is for 3 marks. Local factors and systemic factors. Local factors being foreign body, increased pressure in that particular area, infection, ionizing radiation to that particular area, poor blood supply, and location and extent. Where is it located and how far is it extending? Next is systemic. In case of systemic factors, it is hormones. Glucocorticoids, they decrease the inflammation. How are they going to decrease inflammation? They are going to decrease the collagen. Once they are going to decrease the collagen, they are going to decrease the TGF beta. If TGF beta is decreased, then there is no fibrosis and there is no wound healing. Then hypovolemia or shock. Then diabetes mellitus and nutritional deficiency like vitamin C and zinc. Okay, vitamin C and zinc are very important. What are the disorders of wound healing? Disorders of wound healing are like delayed healing because of diabetes mellitus or vitamin C deficiency. There is decreased blood supply and foreign body precipitation in that particular area. And deficient scar formation. One is delayed and deficient scar formation or scar adhesions. That is called as decrease the scar formation. There is improper repair mechanism. Or there is excessive healing, that particular excessive healing will be of 2 types. One is hypertrophic scar, the other one is keloid. This is what about we have told him regarding the wound healing. Next we are going to tell regarding the leprosy. What is leprosy? Leprosy is a disease which is affecting the skin, peripheral nerves, upper respiratory tract mucosa, which is caused by gram-negative bacilli, that is Mycobacterium leprae. So what are the key components you are going to write in definition? It is going to affect skin, peripheral nerves, upper respiratory tract, and Mycobacterium lepra, the causative agent. What is the route of transmission? Route of transmission should be droplet inhalation via nose or mouth. Next, pathogenesis. Since the Mycobacterium leprae is always intracellular, it is taken up by the macrophages. Once it is taken up by the macrophages, it is disseminated into the blood. Okay, the macrophages in the blood, they are called as monocytes, and it is disseminated into the blood. And once if they are disseminated into the blood, what happens? It gets concentrated in the cooler tissues for its replications. Okay, cooler tissues, it requires cool temperature for the replication. So over a period of 1 year, the symptoms appear and they become maximum by 5 years. Okay, the incubation period is 5 years. So the leprae bacilli will bind to the Schwann cells and cause nerve injury. So what are the types of nerve injury caused here? One is demyelination, the other one is loss of nerve function. These are the 2 things which is caused by the leprae bacilli. At last, it is identified by our great barrier cells. They are called as CD4 T cells and CD8 T cells. And CD4 T cells bring about the cell-mediated immunity, which is a delayed type. Next is the classification. So, what is the classification? Tuberculoid, borderline tuberculoid, borderline lepromatous, and lepromatous. These are the classification. Next, tuberculoid and lepromatous, you are going to see the differences between, which is very important. What is the site of tuberculoid? It is skin and nerves. Whereas in case of lepromatous, it is skin, peripheral nerves, anterior chamber of eye, upper respiratory tract, hands and feet. This is lepromatous. Okay, this is lepromatous. Whereas inflammatory response or immune response, it is strong here. In case of tuberculosis, it is strong. Th1, okay, Th1 cells are more. Th1 response is more. Here it is weak. Here it is weak. Lepromatous is positive here. Here it is negative. Next, antibody response. Whether antibodies are present in case of tuberculosis? No, there are no antibodies here. The antibodies are present. What about the skin lesions? Skin lesions are just 1 to 5 in number and they are asymmetrical. Here they are asymmetrical. Here it is more than or equal to 5, but they are symmetrical. Next, it is having loss of sensation. There is loss of sensation. Here there is no loss of sensation. Next, nerve involvement. Nerve involvement is present in case of tuberculosis type, whereas it is absent or present in case of lepromatous type. Next, bacillary load. Bacillary load, it is called as paucibacillary. It is called as multibacillary lepromatous. Microscopy, you are going to see, being a tuberculosis, there is TB infection most probably suspecting, and you are going to see granuloma there. Whereas in case of lepromatous, you are going to see the lepra cells. What are these lepra cells? They are lipid laden macrophages with leprabacilli, that is lepra cells. Next, coming to the opportunistic infections in case of HIV or AIDS, candidiasis and cytomegalovirus infection, tuberculosis, salmonellosis, histoplasmosis, cryptococcosis, JC virus infection, which will cause progressive myeloleucopathy, okay, progressive multifocal leucopathy, okay, that is called as leucopathy. Next is cryptosporidiosis and strongyloidosis. These both are parasite, 2 fungi, okay, and mainly bacteria, okay, three fungi, Candida, Histoplasma, Cryptococcus are the 3 fungus. Viruses are JC virus and CMV virus. TB and Salmonella, 2 bacteria, 2 virus, 3 fungi, 2 parasite, only 3. So there is exception is 3 fungi, rest all 2 parasite. Okay, 2 parasites are cryptosporidiosis and strongyloidosis. Okay, 2 viruses are CMV virus and JC virus. 3 fungi are candidiasis, histoplasmosis and cryptococcosis. 2 bacteria are TB and salmonella. Okay, this is what I am going to tell. Next, stains for amyloid. HND stain most commonly used. Then is Congo red, which is very specific for amyloid. Next is Alcian blue, PAS periodic acid skiff, and methyl and crysyl violet, and thioflavin T and S. These are the stains. Next is Ladacious spleen or splenic amyloidosis. Ladacious spleen tells about splenic amyloidosis. So basically this amyloid deposits are going to deposit in 2 types. One is sago spleen, the other one is Ladacious spleen. So sago spleen means limited to the splenic follicles, whereas Ladacious spleen, it is involving both splenic sinuses and the red pulp. So basically the patient will present with splenomegaly. Next we are going to tell in detail regarding the amyloidosis. What is amyloidosis? It is a group of disorders characterized by extracellular deposition of insoluble abnormal amyloid fibrils that alter the function of normal tissue. So these are the 2 keywords. One is extracellular hyaline, extracellular pinkish hyaline, insoluble abnormal amyloid fibrils that alter the function of normal tissue. So what are the properties of amyloid? On electron microscope, they are continuous non-branching fibrils, whereas on X-ray crystallography you are going to see the beta-plated sheets. Classification, there are 2 types, systemic and localized. Systemic, you are going to tell about the light chain immunoglobulins increase, that is in plasma cell disorders, transthyretin in senile cardiac amyloidosis, and A amyloidosis in case of inflammation related, and beta-2 microglobin that is related to dialysis. Next is localized, calcitonin in case of medullary thyroid cancer, you are going to see ACAL type of amyloid there. Then amylin in selenoma and type 2 diabetes mellitus. Keratin, it is cutaneous amyloid. Prolactin, it is pituitary amyloid. Next, the pathogenesis regarding the amyloidosis. Pathogenesis is there is increase in the normal proteins. Either there should be increase in the normal proteins or there should be normal amount of abnormal proteins. Abnormal proteins, how much it is there, it should be present that much only, whereas there should be increase in the normal proteins. So increase in the normal proteins, what does it lead to? Native folded protein and acquired mutations and chronic inflammatory lesions. So because of this there is a fate now, there is next fate. Next is amyloid intermediates are formed here. Amyloid intermediates are formed. So these amyloid intermediates, later they form the beta platelet sheets. Their complete amyloid is formed and that is called as fibril. Fibril is formed now. Next, because of acquired mutations, that is most commonly seen in case of plasma cell disorders, there is increase in the plasma cells. Once these plasma cells are increasing, there is increase in the immunoglobulin light chains and there is restriction of the proteolysis, and that will lead to the formation of AL amyloid. That will lead to the formation of AL amyloid. Whereas chronic inflammatory lesions, they activate the macrophages. Because of this, IL-1 and IL-6 are produced, which act on the hepatocytes and lead to the formation of SAA protein, and that is also leading to the restricted proteolysis, leading to the formation of AA amyloid. Okay, if you don't remember the entire pathway, it seems very difficult. Just write this. Okay, increase native protein and increase acquired mutations and increase chronic inflammatory lesions, that will lead to native folded protein will lead to fibril, acquired mutations will lead to AL type, chronic inflammatory lesions will lead to AA amyloid. Whereas the normal amount of abnormal protein, this you must write full, okay, because it is small. Inherited mutation, there is inherited mutation that will lead to mutant transthyretin, and that is seen in ATTR amyloid. Next is other classification of amyloidosis. One is primary amyloidosis and next is secondary amyloidosis. Primary amyloidosis is usually associated with plasma cell, whereas secondary is due to reactive changes, that is called as reactive amyloidosis. So what is the amyloid seen in case of primary? It is AL type, whereas in case of reactive it is AA type. Here you are going to see more of light chains. You are going to see because of chronic inflammatory disorders such as rheumatoid arthritis, ankylosing spondylitis, inflammatory bowel diseases, tuberculosis infection and leprosy. Do you see amyloid in the grass? No, never. So not seen. In the grass it is not seen. In microscopy you are going to see the extracellular deposits in between the cells which look bright pink in color. They are extracellular deposits between the cells which look bright pink in color. Most common organs to be affected, it is kidney and heart. Kidney and heart are the common organs to be affected. Then it is spleen and liver. Clinical features: in case of renal amyloidosis, there is deposition of this amyloid in between the renal cells and that will lead to nephrotic syndrome. In case of cardiac amyloidosis, that will lead to heart failure, arrhythmia and most commonly restrictive cardiomyopathy. Next is neural amyloidosis. Neural amyloidosis will lead to autonomic and sensory neuropathies. Investigations: you are not going to do the renal biopsy or cardiac biopsy or neural biopsy for amyloidosis diagnosis. You are going to take out the abdominal fat pad, which is very easily accessible. Abdominal fat pad biopsy. You are going to stain it with HND and Congo red. On HND you are going to see the bright pink deposits between the cells, and which is hyaline in nature, and Congo red you are going to see the apple green bifringence. You're going to see the apple green bifringence. So what is the treatment? You're going to correct the protein misfolding. These are the new updates. They have been in the research process. And the next is inhibition of this fibrillogenesis. Inhibition of this particular fibrillogenesis. Next we will deal regarding the HIV or AIDS. Okay, HIV or AIDS. Human immunodeficiency virus infection or acquired immunodeficiency syndrome. So basically, how we are going to define it? This is the most common, right? Most commonly encountered within us in most of the developing countries and developed countries, and most commonly in developing countries. So it's the most common It's the most common secondary immunodeficiency disorder. It's the most common secondary immunodeficiency disorder characterized by profound immunosuppression, opportunistic infections, secondary neoplasms, and neurological manifestations. So, epidemiology or the risk factors: homosexuals for more than 50% risk, heterosexuals for more than 25% risk, IV drug abusers, people requiring repeated blood transfusions such as thalassemia patients and hemophilia patients, and newborn which is infected by a HIV positive mother, and multiple sex partners. Mode of transmission: sexual mode and during the blood transfusion, and next is parental transmission and perinatal transmission. Life cycle: the GP120 receptor on the particular HIV virus is going to bind to the CD4 T cells, and that will cause the conformational change. Once this conformational change is made, the GP120 along with CD4 binds to the CCR5, okay, CCR5 of the CD4 T cells. After this, what happens? The GP41 will cause the membrane penetration. It will enter into the membrane, that is called as membrane penetration. Next is membrane fusion. Then fusion of this HIV membrane with the host cell membrane. Fusion of HIV membrane with host cell membrane. After this fusion is occurring, the HIV already is inside now, and the viral genome will be put inside the cytoplasm of the human cell cytoplasm. Pathogenesis. First is primary infection. What is primary infection? That is HIV will come in contact with the new or naive CD4 T cells and establishment of infection in the lymphoid tissue, local tissue. First is local tissue, that is lymphoid tissue. Then what happens? Then you are going to cause the massive viremia. How it is caused? Wide dissemination to the lymphoid organs, various lymphoid organs. The lymph tissue will be supplied by the lymphatic side. It will be draining by that, right? Then it will spread that particular virus into the so many lymphoid organs. After this, what happens is trapping of virus, okay? Trapping of virus and establishing of persistent or chronic infection. Now the body will trap this virus, and that will lead to the chronic and persistent infection. Next is immune activation by cytokines. Immune mediated activation, okay? Immune activation mediated by cytokines. Cytokines are released, and HIV envelope mediated aberrant cell signaling. Cell will be signaled, and the immune system will mediate it via cytokines. After this, there is accelerated virus replication, so much that the virus replication is very peak now. So now there is a partial immune control of the virus replication. Immune control is partial only. There is no peculiar system to be halting this particular replication, and there is rapid CD4 T cell turnover, because this particular HIV, it requires it for the replication, because virus being an intracellular, it requires a cell or host. Now there is a rapid CD4 T cell turnover, and that will lead to destruction of immune response. Course of disease. There are three phases. First phase is acute retroviral syndrome. Second is middle chronic phase that has led to asymptomatic stage, and the next is persistent generalized lymphadenopathy. Third is AIDS. AIDS is a syndrome of so many components inside it. So what are the clinical features in this particular AIDS? You're going to see fever, weight loss, diarrhea, generalized lymphadenopathy, repeated infections. All these are seen. How are you going to diagnose? You're going to diagnose by ELISA and RT-PCR. ELISA and RT-PCR are the diagnostic categories. Next, treatment. You're going to treat with TLD regimen. So what is a TLD regimen? Tenofovir, lamivudine, and dolutegravir. These are the things you're going to use for antiretroviral therapy. Next, we will tell regarding the hypersensitivity reaction. Hypersensitive reactions are of 4 types. So what are these hypersensitivity reactions? They are exaggerated immune response to antigens. That's called as hypersensitivity reaction. That is exaggerated. So there are 3 types: 1, 2, 3, 4. 1, 2, 3 are antibody mediated. 4 is cell mediated. Next, pathogenesis of type 1. On the first exposure, the body sensitized to the allergen. So the antigen will bind to the skin. In the skin, there is something called as Langerhans cells. They are antigen presenting cells. They bring the antigen to the T cell, they bring it to the T cell, and there is activation of Th2 cells. Once there is activation of Th2 cells, there is interleukin 4 and interleukin 5. Interleukin 4 will produce IgE, that's why type 1 is IgE mediated, and it acts on mast cells. After mast cells are activating on the repeated exposure, that will lead to mast cell degranulation. Okay, sorry, it was not seen right, I'll repeat it. Antigen in the antigen will bind to the skin, and there is something called as APCs, that is Langerhans cells. So this particular antigen will be presented to the T cell, and after presentation it will lead to the activation of Th2, that is T helper cells type 2. Then they release interleukin 4 and interleukin 5, and interleukin 4 produces IgE, and it acts on mast cell, and on repeated exposure the mast cell will degranulate. So there are two types of reaction. This interleukin 5 will recruit eosinophil, that's what the function. Next, mast cell degranulation early features are vasodilatation, increased vascular permeability, and bronchospasm, that is brought about by histamine. Next is late, after 2 hours, that is epithelial damage and tissue restriction brought about by leukotrienes, cytokines, and chemokines. So what are the examples? Here? All the allergic conditions: bronchial asthma, hay fever, atopic dermatitis, allergic rhinitis, allergic dermatitis, and food or pollen allergy. All these are okay. Bronchial asthma, hay fever, atopic dermatitis, allergic rhinitis, allergic dermatitis. Last is food or pollen allergy. Next, type 2. Antibodies are directed against fixed antigens. Here there is a fixed antigens against which the antibodies are activated. There are two types of fixation. One is on the cell surface, one is on the basement membrane. Okay, one is on the cell surface, the other one is on the basement membrane. There is antigen-antibody combination occurring on the cell surface. So the next, in the basement membrane, the antigen is fixed on the basement membrane now. So for the particular antigen which is on the basement membrane will combine to the antibody on the basement membrane itself. So in the first step, what you have seen, antigen-antibody combination, it is going to cause either destruction or dysregulation. There are two types: destruction of the target cells or dysregulation of target cells. In case of destruction, that will lead to opsonization activation and complement activation and cell destroyed. Next is dysregulation, which is mainly seen in case of myasthenia gravis and Graves' disease. So what happens in case of basement membrane related antibody antigen reaction? There is activation of complement pathway. Once the complement pathway is activated, you are going to see C3A and C5A, and what they do, they recruit neutrophils. Once the neutrophils are recruited, these neutrophils will produce enzymes and they destroy the basement membrane. So what are the examples here? Myasthenia gravis and Graves' disease I have mentioned here. Myasthenia gravis and Graves' disease, where there is dysregulation of target cells. Next is Goodpasture's syndrome. Then is immune hemolytic anemia and immune thrombocytopenic purpura. These are the things: ITP, immune hemolytic anemia, Goodpasture syndrome, Graves' disease, and myasthenia gravis. Next we will deal regarding the type 3. Okay, type 3 hypersensitivity reaction. So it occurs in three phases. One is formation of immune complex, second one is deposition of immune complex, last is immune complex mediated tissue injury. So formation of immune complexes is by antigen and antibody. They combine to form the immune complex, which takes about 5 to 7 days. Next is deposition. Most commonly is seen in case of kidney, blood vessels, and skin. Okay, that is where the deposition is seen. Next is tissue injury. Tissue injury is most commonly because of complement activation and Hagerman factors activation. These are the two things we are going to see. Next, tissue destruction. Because of this complement activation and Hagerman factor activation, you are going to see the tissue destruction, and that will take 10 to 14 days. So mnemonic here is SHARP. The mnemonic for type 3 hypersensitivity reaction: S for SLE and serum sickness, H for Henoch-Schönlein purpura, A for Arthur's reaction, R for reactive arthritis, P for post-streptococcal glomerulonephritis and polyarthritis nodosa. Arthur's reaction. What is Arthur's reaction? Arthur's reaction is a localized area of tissue necrosis. It is a localized area of tissue necrosis characterized by what? In situ, you are going to see antigen and antibody complexes usually after intradermal injection. So key component, keywords are localized. It is localized. It is having in situ antigen antibody complexes usually after intradermal injections. It is seen in previously sensitized host. Okay, he should be already having the circulating antibodies for that particular antigen. There you are going to see this particular arthros reaction manifest. How are you going to manifest? They are going to have the local vasculitis due to IgG deposition there. Then you are going to see also seen in case of administration of tetanus toxide and diphtheria toxide administration. After that you are going to see the arthros reaction. Next, type 4. Type 4 hypersensitivity reaction is a cell mediated and it is delayed type. So the antigens what here they take, it is taken up by the antigen presenting cells and they are going to bring it to CD4 cells and CD4 T cells. Okay, CD4 T cells and CD8 T cells, what is their function? CD4 T cells, they activate the helper cells and produce IL-1, IL-12 and interferon gamma. So IL-1, IL-12 will recruit new lymphocytes, whereas interferon gamma will form the granuloma. Whereas CD8 T cells, what does it do? They destroy the virus cells or the tumor cells directly by FAS and FAS alpha mechanism, FAS alpha mechanism or perforin mechanism or by perforin mechanism. Next, regarding the examples. So what are the examples here? Granulomatous disorders like TB, leprosy. Okay, so the diagnostic test for them also: tuberculin test, lepromin test, inflammatory bowel disorders, rheumatoid arthritis, and multiple sclerosis. These are the things you are going to tell regarding the hypersensitivity reaction. So we are done with the inflammation chapter. Now we are going to move to the hemodynamic disorders. In that, first we are going to deal regarding the edema. Okay, we are going to tell about the edema. So what is edema? Abnormal or excessive accumulation of free fluid where in interstitial space or tissue space. It is called as tissue space and serous cavities. So there are different types of edema definition. One is diffuse, that is called as anasarca or dropsy. Next, abdomen, it is called ascites. In pleural space, it is called as pleural effusion. In case of pericardium, it is called as pericardial effusion. In case of thoracic cavity, it is called as hydrothorax. So how are we going to differentiate between transudate and exudate? Here is the difference. Next, coming to the causes of transudate, it is usually increase in the hydrostatic pressure and decrease in oncotic pressure. Here it is exudative, that is due to increased capillary permeability. The mechanism of action is different or the cause is different. States. So what are the different pathological states which are responsible here? Congestive heart failure, hypoproteinemia and nephrotic syndrome. Okay, these are the things. Whereas in case of exudative, it is because of inflammation, mainly acute inflammation. Endothelial permeability is normal in case of transudate. Here it is affected because of acute inflammation. Then fluid nature, it is ultrafiltrate. Here it is inflammation, extracellular fluid. Okay, due to inflammation there is extravascular fluid. Next, composition, it is water and dissolved electrolytes. It is having water and dissolved electrolytes inside it. Exudates will have proteins and cellular debris. Color, it is straw colored. Here it is yellowish white. pH, here it is more than 7.5, here it is less than 7.3. More than 7.3, it is less than 7.3. Specific gravity is less than 1.012, here it is more than 1.020. Protein, it is decreased. Okay, proteins is decreased in case of transudate, whereas in exudate proteins are more because of cellular debris, and proteins are present in case of exudative fluid. That is more than 3 gram per deciliter. Here it is less than 3 gram per deciliter. Glucose, it is same as that of blood, there is no change. Okay, whereas in case of infection the bacteria will be taking out the glucose, so the glucose is decreased in case of exudate. Next, the ratio of LDH fluid to the LDH serum is reduced in case of transudative, whereas it is increased in case of exudative. Light microscopic features, you're going to not see the inflammatory cells here. Whereas in case of exudative, you're going to see the neutrophils and macrophages. Please mark them. Next, pathogenesis. Pathogenesis is based on the mechanism. One is because of increased hydrostatic pressure. Next is decreased oncotic pressure in the plasma and lymphatic obstruction, sodium retention and inflammation. These are the 5 mechanisms proposed for edema. Based on that, you are going to tell increased hydrostatic pressure will lead to, as is seen in congestive heart failure, ascites and thrombosis, whereas decreased plasma oncotic pressure is seen in case of protein energy malnutrition, cirrhosis and PLE, that is protein losing enteropathy. Next is lymphatic obstruction. Lymphatic obstruction lead to inflammation and neoplasm. Okay. Next is sodium retention. If there is a sodium retention, then there is renal hypoperfusion and overactivity of RAS system. Inflammation is of 2 types, that is acute and chronic. So edema in case of heart failure, how is it going to happen? If there is a heart failure, what happens? There is decrease in the renal blood flow and increase in the capillary hydrostatic pressure. If there is an increase in the capillary hydrostatic pressure, that will lead to edema directly, right? So if there is a decrease in renal blood flow, that will activate the RAS. So what is the function of RAS? It is going to retain the sodium and water and increase the blood volume. Okay, and increase the blood volume, and that will lead to edema. Next, renal failure will directly lead to retention of sodium and water, and that will lead to edema. This is what about heart failure. Whereas if you are curious, in case of protein energy malnutrition and nephrotic syndrome, there is decrease in the plasma albumin. So if there is protein is less in the plasma, that will lead to decreased plasma oncotic pressure, and that will lead to edema, right? Next, morphology. There are different types of morphological edema. One is subcutaneous edema, that is of 2 subtypes, pitting and non-pitting. Pitting is seen in case of renal failure and heart failure, whereas non-pitting is seen in mixed edema. Periorbital edema is again seen in case of renal dysfunction. Pulmonary edema is due to acute respiratory distress syndrome and cardiogenic induced pulmonary edema, that is called as cardiogenic induced pulmonary edema. Next is cerebral edema, that is due to trauma or road traffic accidents and effusions. Effusions are seen in thoracic cavity, they are called as hydrothorax. In case of abdomen, it is called as ascites. In case of pericardium, it is called as pericardial effusion. So what are the clinical features? If he is having a pulmonary edema, he will be presenting with dyspnea and pink frothy sputum in case of pulmonary edema, and altered sensorium in case of cerebral edema, and abdominal discomfort in case of abdominal edema, that is ascites. Okay, these are the things you must concentrate in edema. Next, coming to the next emergency, that is embolism. Okay, that is embolism. So embolism, what is embolism? What is emboli? Emboli is a detached intravascular solid or liquid or gaseous mass. Okay, it is a detached intravascular solid or liquid or gaseous mass that is carried from the site of origin to the distant site in the blood, and that will lead to tissue dysfunction or infarction. Okay, that will lead to tissue dysfunction or infarction. What are the types of emboli? Physical, based on the physical, it is solid, liquid and gas. Solid, it is thromboemboli and atheromatosis emboli. Sorry, liquid, it is fat. Okay, liquid, it is fat. And bone marrow and amniotic fluid. Gas, it is air. Gas, it is air. Next, infection, whether infection is present or absent. If it is present, it is septoemboli. I have written both present, sorry. If it is negative or absent, okay, if it is absent, then it is called as bland. Bland emboli. Source, it can be exogenous or endogenous. Next, origin, it can be pulmonary or systemic. Pulmonary embolism most commonly originate. So we are going to concentrate many embolisms here. I am going to subdivide them, and I am going to tell in bits about embolism, since embolism is a 10 marker question for you people. Pulmonary embolism mostly originate from the deep veins. Okay, deep vein thrombi, they are called as deep vein thrombi, and it is most common. What are risk factors? Just after the surgery, post surgery, okay, the embolus will be moving there, and prolonged immobilization, the embolus will be there, and suddenly you are going to get up, and that will cause movement of the emboli, and increased age and obese persons and pregnancy. These are all the risk factors for pulmonary embolism. Fate, what is the fate of this particular pulmonary embolism? It lead to massive pulmonary embolism, okay, if there is a more than 60% obstruction. If the particular emboli is going to obstruct more than 60%, then that will lead to massive pulmonary embolism. And if the emboli is present in the pulmonary artery, that is called as saddle embolus, okay, that is called as saddle embolus. What are the consequences or the complications? Consequences or the complications are infarction and hemorrhage in the pulmonary field. What is the clinical features? What are clinical features? Cough, stabbing or the pleuritic pain, shortness of breath, and rarely hemoptysis. Sudden death also is seen, okay, most of the time sudden death is also seen. Systemic thromboembolism, embolus in which emboli occlude the systemic artery. Here systemic artery is involved. Systemic artery is involved, okay. Embolism in which emboli occlude the systemic artery circulation. So cardiac cause, what is the cardiac cause there? Cardiac cause is intramural thrombi, which is present inside the heart itself, that is called as intramural thrombi. Whereas vascular cause, thrombi which is on ulcerated atherosclerotic plates. Intramural thrombi is formed because of what? There should be some precipitating event rate. It is always secondary because of myocardial infarction or atrial fibrillation. AF here is atrial fibrillation, not amniotic fluid embolism. It is atrial fibrillation. Next is consequence. If there is a systemic artery occluding, what does it cause? There is decrease in blood supply, and that will lead to ischemia, and ischemia will lead to necrosis. And the same artery is getting occluded in case of brain, that will cause stroke. If in heart it will cause MI. In case of GIT it will cause mesenteric ischemia. Next, fat embolism. Fat embolism. Presence of emboli comprising of fat microglobules. You are going to see the fat microglobules here. What are the causes here? Because of fracture of long bones and extensive trauma and burns. Clinical features being respiratory distress, tachypnea, petechial hemorrhages, neurological manifestations such as irritability, restlessness, delirium, and loss of consciousness. LOC means loss of consciousness. What is the pathogenesis? There are two types of pathogenesis. One is mechanical injury, the other one is biochemical injury. Mechanical and biochemical. So what is the mechanical pathway? The fat microglobuli with RBCs will aggregate with the platelets and form the mechanical obstruction. Okay, the fat microglobuli will combine with the RBCs and platelets to form the mechanical obstruction. Next, the fat globules will release the free fatty acids, and they cause the local toxic injury to the vascular endothelium, and that will bring about the platelet aggregation and WBC recruitment. Okay, and that will lead to fat embolism. Next is lab diagnosis. You are going to do the bronchoalveolar lavage, and there you are going to see fat laden alveolar macrophages. Fat laden alveolar macrophages, which is seen because of oil red O or Sudan black staining. They are the special stains used for fat, right? Then histopathology. Histopathology on autopsy. On autopsy, you are going to see the fat globules inside the pulmonary artery and the alveoli of the lung. Air embolism. Air embolism. Air embolism is air is introduced inside the venous or atrial circulation, that is called as air embolism. What are the causes? Trauma, surgical procedures such as laparotomies or laparoscopic surgeries. Next is abortions. Okay, abortions and decompression sicknesses. These are the causes of air embolism. So amniotic fluid embolism. What is amniotic fluid embolism? Very severe complications of labor that develops because of amniotic fluid and fetal debris entering into the maternal circulation. Okay, the amniotic fluid along with the fetal debris, it is going to enter inside the maternal circulation due to rupture of blood vessels or tear in the placental membranes. So amniotic fluid, what does it do? It is going to enter the venous circulation, then it will enter the right heart, and lastly it will enter the pulmonary artery. What is the complication here? Fatal DIC. Fatal DIC. Next we'll talk about the thrombosis. So what is thrombosis? Process of formation of solid mass. Okay, thrombosis is process of formation of solid mass in the circulating blood from the constituents of blood containing platelet and fibrin. Okay, there is a formation of this solid mass inside the blood itself, from where the constituents of blood itself. Okay, inside the circulating blood, which contains the constituents of the blood such as platelets and fibrin. What is the pathogenesis? Pathogenesis is Virchow triad. What does it comprise of? Endothelial injury, abnormal blood flow, and hypercoagulability. Okay, hypercoagulability. So if there is increased endothelial injury, what does it do? It will cause increased platelet adhesion to the endoplasm and endothelium, and that will lead to thrombus formation, and that formed thrombus will enter heart chambers. Now next, abnormal blood flow will cause endothelial injury, and that will activate prothrombotic activities. Next, hypercoagulable states will mainly because of genetic, that is most common is factor 5 laden mutation. All this will cause lead to the formation of thrombosis. Morphologically, there are two types, arterial and venous. Arterial is also called as cardiac, and that is leading to mural thrombi, whereas venous is always secondary to stasis. What is the fate of thrombosis? One is propagation, 3 marker question it is. Propagation, embolization, either it will propagate, okay, thrombus will become big, that is called as propagation. Next is embolization, that thrombi will become a emboli, that is called as embolization. Next is dissolution, that thrombus may dissolve, that is called as dissolution. Next is organization and recanalization, it becomes organized and it will enter the various organs and becomes recanalized. Next is venous thrombosis and arterial thrombosis. Venous thrombosis is seen in superficial and deep. In case of superficial veins, that is leading to varicose veins, whereas deep vein thrombosis is seen in large leg veins such as popliteal, femoral and iliac veins are seen. And this deep vein thrombosis is very risky, and it is most commonly seen in case of pregnant individuals, and it is associated with heart failure, and the treatment for it is bed rest and immobilization are the treatment for it. Arterial thrombosis is because of atherosclerosis, mainly because of atherosclerosis, that is seen in case of diabetes mellitus and smoking patients, and MI is also a precipitating event. So this particular arterial thrombosis, if there is a thrombi in the artery, that will lead to infarction and ischemia of that particular tissue. Next is chronic venous congestion of the lung and chronic venous congestion of the liver. These two things you must remember, because the diagrams are also important, and as the back going to tell regarding the features also. Chronic venous congestion is because of left heart failure, whereas in case of CVC liver it is right heart failure. What is the mechanism here? So what is the main culprit in case of chronic venous congestion? What is congestion? Congestion is because of what? There is increased venous blood. Okay, there is increased venous blood stasis that has led to. If there is increase in the arterial blood to the organ, that is called as hyperemia, whereas congestion is increase in the venous blood, and that has led to the congestion. Here in left heart failure, that lead to backflow of the blood into the left atrium. So that left atrium will be having overload, it can't bear like left ventricle, and it will send back into the pulmonary vein, and the pulmonary veins are coming from the lungs, so now they go back into the veins of the lungs and they get congested. Okay, the congestion of the pulmonary veins in the lungs, they are called as CVC lung. So what is the gross features? What are the gross features? Gross features, it looks browny indurated. Okay, it looks browny indurated or bronze in color, edematous and bulky. Okay, lungs look like this. Whereas microscopy, what you're going to see? You're going to see interstitial edema, alveolar edema and heart failure cells. These are the three things you're going to concentrate on microscopy. Whereas a CVC liver, what is the cause? It is right heart failure. Because of right heart failure, there is a backflow of blood into the systemic circulation, that is superior vena cava and the inferior vena cava. From the inferior vena cava, they go back into the hepatic veins. After coming back from the hepatic veins, they get congested inside the liver, and that will lead to chronic venous congestion of the liver. So how does it look in the gross? It will look nutmeg appearance, that is alternative dark band and white band. Dark band indicates congestion, whereas white band indicates normal liver or reduced blood supplied area. Microscopy, you're going to see three features. One is central hemorrhagic necrosis. Second one is fatty change in the middle zone, and in the peripheral zone you're going to see the normal portal triad. The central area is you're going to see the central vein, and surrounding it you're going to see the central hemorrhagic necrosis because the vein is damaged now, so that will lead to necrosis in the central region. So you're going to see the necrosis in the central region. In the middle zone you're going to see the fatty changes because of hypoxia, and the last zone, the third zone, you're going to see the normal zone because it is preserved because of the supply of hepatic artery. Next we're going to tell regarding the neoplasia. Next we're going to move regarding the chapter of neoplasia. So in the neoplasia, what you're going to tell? What is metastasis? Metastasis is important. Okay, metastasis is important. So how we are going to define the metastasis? It is the most reliable feature of malignancy. Defined as spread of tumor to the distant sites that are physically discontinuous. It is physically discontinuous. Distant sites. Okay, distant sites should be mentioned. It is important. Next, pathways of spread. One is direct, next is lymphatic, and is hematogenous. I will not explain in detail all things. You are going to concentrate on them. Now I will tell about the types of metastasis which occur in our body. One is local invasion, the other one is distant metastasis. Okay. Local invasion. First is there is a separation between the cancer cells, that is called as dissociation of cancer cells. There is dissociation. There is a gap formation in between the cells. Okay, there is a gap formation between the cancer cells. Next is ECM degradation, that is extracellular matrix degradation. Via whom? Who will do this? There it is done by, right now, matrix metalloproteinases. They are called as MMP. In short, I have written MMPs, that is matrix metalloproteinases. They do the extracellular matrix degradation. Next, after doing that, there is attachment of the tumor cells to the ECM component. Now the ECM component is attached by the tumor cells. Attachment of the tumor cells to ECM components. Next, last is locomotion of the tumor cells. The tumor cells will start moving. Okay, it starts moving to the different directions. Okay, and bring about the actions. Next is distant metastasis. So in distant metastasis there are various steps you must remember. First is clonal expansion. There is one clone. Okay, this is one cell that is called as clone, and that will lead to clonal expansion via growth and angiogenesis. Growth factors are activated and angiogenesis is also activated. And there is primary tumor. Okay, there is from primary tumor. This is the primary tumor which I have marked in the red. That is primary tumor, and that will lead to metastatic subclone. Now clone is there, subclone is formed. That is called as metastatic subclone. Later what happens? There is intravasation. Okay, sorry. After metastatic subclone, there is adhesion to the basement membrane. The particular tumor cells will adhere to the basement membrane. They will adhere to the basement membrane. After adhering to the basement membrane, they will invade the basement membrane. That is called as intravasation. Next, once they are entering the blood vessel, they are going to encounter with the lymphocyte. Okay, there is interaction with the host lymphocytes. Next, tumor cell embolus. Okay, tumor cell embolus is formed. Emboli is formed via the platelets. Platelets are there. They are going to form the embolus now. So once the embolus is formed, next there is extravasation. Last is extravasation. They are going to seed out, right? They are going to spread it, so they are going to come out. That's called as extravasation. Next is metastatic deposit outside. This particular thing is called as extravasation, coming out, and this particular thing is called as metastatic deposit. Last, after the metastatic deposit is formed, you are going to see the angiogenesis and growth of that particular thing. That is called as metastasis. Next, difference between benign and malignant. Difference between benign and malignant. How are you going to define? Benign is well defined. Malignant is lack of differentiation or poor. Benign structure is similar to the original tissue, whereas it is atypical. It is not similar. there is no anaplasia here or little anaplasia is present. Here there is significant anaplasia. Anaplasia means lack of differentiation. Next is slow growth. Here it is rapid growth. Here it is mitotic factors are rarely seen. Here they are abnormally numerous in number. There is no invasion here, that is called as non-invading. Here it is locally invasive or infiltrative. If they are not involved in that particular MCQ is called as cohesive and expansile, whereas locally invasive it is infiltrative. Here it is capsulated, here it is non-capsulated. Here the metastasis is absent. Here the metastasis is absent. Here the metastasis is present. So what are the examples? The corresponding benign and malignant I have written. The corresponding benign is called as cystadenoma. The corresponding thing in the carcinoma is cystadenoma carcinoma. It's called as cystadenoma carcinoma. Next is adenoma. Adenoma, the corresponding is adenocarcinoma. Next is osteoma. Here in benign, there it is osteosarcoma. Leiomyoma in benign, leiomyosarcoma in malignant. Hepatic adenoma in benign, hepatocellular carcinoma in case of malignant. So next we are going to talk about carcinogenesis. Okay, carcinogenesis. Carcinogenesis, there are two things which have been asked in your exams, that is chemical carcinogenesis and microbial carcinogenesis. So main pathogenesis I have written in case of chemical, whereas two viruses have been discussed in microbial carcinogenesis, which you must concentrate, and the agents I have written at the last. So in the chemical carcinogenesis, there is a carcinogen that will lead to the metabolic activation. Okay, the metabolic pathway is activated because of this particular carcinogen, and that will lead to the electrophilic intermediates. Okay, intermediates of the electrophile is formed there, called as electrophile intermediates. If the kidney is normal, this particular metabolites and the electrophilic intermediates, they are purified via excretion. If there is no kidney abnormality, this all process happens smoothly. If there is kidney abnormality, then this particular electrophilic intermediates, what they do, they bind to the DNA. They are not removed by the kidney. Now they bind to the DNA and they cause the permanent DNA lesion. Permanent DNA lesion is formed. Once this permanent DNA lesion is formed, this damaged DNA, this particular damaged DNA leads to the cell proliferation and altered differentiation. The same damaged DNA will cell proliferation and altered differentiation. Okay, cell proliferation and altered differentiation. Next is paraneoplastic clone is formed. Formation of paraneoplastic clone and proliferation of it. It is formed now, then it will proliferate. Lastly, it will become malignant neoplasm. So what are the agents of chemical carcinogenesis? Benzidine, dimethylaminoazobenzene and beta propiolactone, dimethyl sulfate and 1-acetyl imidazole. These are the agents of chemical carcinogenesis. Coming to the microbial carcinogenesis, there are two viruses you must remember. One is HPV and next is EBV. HPV is human papillomavirus, EBV is Epstein-Barr virus. So HPV, there is two components. One is E6 component, the other one is E7 component. E6 component, what does it do? It will increase the telomere expression. Next, it will inhibit P53. Whereas E7, it will inhibit P21 and increase cyclin D. Okay, increase cyclin D, but inhibit retinoblastoma gene. Okay. So because of all these factors, what happens? There is increased cell proliferation. And genomic instability. And HPV will lead to cervical cancer in the last. Whereas in case of EBV, what happens in case of EBV? There is latent infection. Okay, there is latent infection of EBV that will lead to polygonal B cell expansion. Okay, polyclonal B cell expansion, and that will lead to increased MYC protein expression. There is increased MYC protein expression, and that will lead to outgrowth of the neoplasm clone, and that will ultimately lead to Burkitt's lymphoma. So EBV is associated with Burkitt's lymphoma, right? So Next, agents. What are the agents of microbial carcinogenesis? These flowcharts you must put, okay? These flowcharts are very much necessary and they are very important also if they ask microbial carcinogenesis. Next, agents. Hepatitis B virus and hepatitis C virus, they cause hepatocellular carcinoma, whereas H. pylori cause gastric carcinoma, and HHV8 will cause Kaposi's sarcoma, and HTLV1 will cause adult T cell leukemia. These are the things which are caused by the viruses, you must remember. Next, lastly, we are going to talk about the tumor markers. This is the definition of particular tumor markers. Biomarkers, these are the biomarkers which are found in the blood and body fluids, okay? They are found in the blood and body fluids that can be elevated by presence of tumor, okay? That can be elevated by presence of tumor. So what are the uses of this particular tumor markers? One is screening. It is used for screening of the disease. Next is diagnosis. Next is confirmation. You are going to monitor the disease after the treatment. Then staging. Then assessment of prognosis. Assessment of treatment response. All these things are the uses of tumor markers. Next, what are the tumor markers elevated in particular diseases? Alpha fetoprotein in case of HCC, alpha fetoprotein in case of HCC, CA in case of CA colon most commonly. Next, calcitonin in case of medullary thyroid cancer. Next, CA19/19, very specific for carcinoma pancreas. Next is CA125, that is for surface epithelial ovarian tumor. Next is PLP. I will discuss all ovarian tumors and all the tumors in the next systemic pathology. I will tell all these things there, okay? Next is placental alkaline phosphatase, that is PLAP. I have missed A here. You are going to add it. PLAP, PLAP. Placental alkaline phosphatase, that is common for seminoma. Next is immunoglobulins. If immunoglobulins are increased, that is called as multiple myeloma. Next, protein specific antigen. It is in case of prostatic cancer, whereas neuron specific enolase, NSE means neuron specific enolase, that is seen in case of neuroblastoma and small cell carcinoma of the lung. Whereas beta HCG, it is quite common in case of choriocarcinoma and germ cell tumors, okay? Germ cell tumors. So this is what all regarding the general pathology. I hope I have covered what are the important topics you must cover before the exams. So if you're going to like the session, please like, share and subscribe my channel and share it for the needy people. And see you in the next video, that is systemic pathology. I'll be dealing the Revisionexpress. Thank you.